thank you everybody for joining us today in our latest Ask the Experts session. My name is Terry Thorson, as most of you know, with Spinal Cord Injury BC, and I'm going to be your host for today. I'd also like to take this opportunity to thank our sponsor of these sessions, the Craig H. Nielsen Foundation, so thank you so much. As you all know, SCI BC partnered with Dr. Krasiakoff on this grant, and I believe we have one last session to go, which will be next week. This is your chance to ask these health professionals specific questions about COVID-19 and SCI. So today, we are very grateful to have our special guest expert, Dr. Jennifer Grant, medical microbiologist and infectious disease physician at Vancouver General Hospital. So Dr. Grant, thank you so much for being here with us today. So perhaps we can just get started with you doing a more full introduction of yourself and maybe a little bit of information you have about this disease and maybe how it affects people with spinal cord injury.
So hello, everybody. As Terry said, I'm an infectious diseases specialist. I also do medical microbiology and infection control. Right now I'm at Richmond Hospital, but I have, at least in the past, had responsibility for JF Strong's infection control program as well. So that's who I am. And I understand that we're talking to people who have various levels of spinal cord injury, and they've submitted some questions, which were great. I wanted to sort of talk a little bit about COVID first. What it is a virus, as you all know. It's a respiratory virus. And the thing that's really interesting about this virus is that it really has multiple faces. So for some people, it's an incredibly mild disease. In fact, for many people, it's asymptomatic. For other people, it's a flu-like illness. You might be out for a couple of days or even up to a week. And for some people, it's quite devastating. And the truth is, as much as we'd like to say we know, we're not 100% sure about what makes one person the person who gets very severe disease versus somebody who gets mild disease. We do know that generally speaking, the very young are relatively unlikely to get disease, probably unlikely to spread it. Although there's a degree of debate in the literature about children specifically. And as you get older and older, you get at a higher and higher risk, and that's especially true for people with some sort of underlying medical conditions. The ones that have been really sort of popped out as being something that's higher risk are heart conditions, lung conditions, diabetes, and obesity. Those are the ones that seem to come out recurrently. Other health conditions, not so clear. And we did actually try and do a literature search specifically for the spinal cord injured population. And I was unable to find essentially anything looking specifically at that patient group. I suspect that because you represent a fairly small proportion of the population, that there probably isn't enough volume to really know. The other thing is it may be that it's not being spinal cord injured that puts you at risk in any one way or another, but rather the other aspects of your health, whether you have heart disease, whether you smoke, other things other than the spinal cord injury that are pertinent. So that's what we sort of tried to do to figure people out. I do want to say that, you know, people with spinal cord injuries, depending on where the injury is, have specific risk factors that need to be concerned about. Those people who need to have a lot of other people helping in their care, obviously social distancing is not possible. And so then how do we manage that in the context of people who are coming in and out of the home, for example? And I think some of those questions have asked those questions, so I'll try and address those. I'm going to move on to the questions. Were there any things that needed to be addressed before I went to those?
No, I think you're all right to go ahead with those questions.
Okay, so the first question I have, I'm just pulling this off a list of questions that Terry sent me, is should we consider stricter quarantine during the fall and winter flu season? So that's a really good question, and the honest truth to that is we actually don't know. The general pattern for respiratory viruses, and usually that's sort of our stand-in for influenza, influenza definitely disappears during the summer and then comes back during the winter. We don't 100% know why. It may be either because UV light tends to kill viruses, which is true, or whether people are just more out and about outside and not in closed environments where viruses tend to spread more. But that's something we see in North America. In our summer, flu goes away, and it actually goes and moves to Australia, which is their winter, and then comes back to us in our winter. Will coronavirus do that? We actually don't know. And the only way we're going to find out is actually by observing and making sure that from a public health point of view, we're following this virus over time. What I would do in terms of your own behavior is really listen to what public health is saying, because they're going to be able to say either we have no transmission in the community, there's no need to worry, or we're starting to see transmission in the community, we'd like it if you started to do more social distancing, etc. So it really is a play it by ear thing. I wish I could give you an absolute answer, but that really seems to be where everyone's at. No one's 100% sure exactly what the future is going to bring. So the next question I have is, does COVID-19 survive on hard surfaces? If yes, for how long? And does it change by material, cardboard versus metal? And the answer to that is yes. There's actually a lovely New England Journal article, which I would love to show to you. I've pulled it up. So this was actually an experiment. Now keep in mind that this is an absolutely 100% artificial experiment. They took virus, they mixed it up in a big batch, made it in a concentration that probably is higher than we would see in somebody with an infection, and then sprayed it on different surfaces. So basically what you're looking at here is hours. So this is time, and this is the amount of virus that they can detect. So it's the amount of virus that's going away over time. Ignore this side because this is completely artificial. They actually took an atomizer and tried to see how much they could get it to stay in the air. And you can do that artificially quite easily, and multiple things have shown that. But here you have copper, and copper you can see, you start with quite a high virus titer, and it just drops down quite quickly. Cardboard also drops down quite quickly. Stainless steel tends to hold things longer, as does plastic. And if you actually look at this bottom graphic, which I will try and move up on my screen. Oh, that doesn't move it up. What moves it up? There you go. On the bottom of the screen, this is the half-life in hours. So essentially on copper, the half-life is quite low. It's about an hour. Cardboard, 2.5 to 4 hours. Stainless steel and plastic, the harder surfaces, this lasts longer. How does that translate in the real world? It depends on how much virus is put on a surface, but there's also a whole bunch of other environmental factors that play into that. So if you're outside in the sun, UV light is very quickly fatal to viruses. If you're in a warm, humid environment, that tends to make things go away a little bit quicker. So all of that to say that yes, things will stay on surfaces. How long depends very much on a whole number of factors, all of which sort of change over time. So there's no way to say, I touch it with a virus and it's going to be there for 4 hours. But you can sort of see there's sort of a bit of an average out here in terms of how long things can stay in on a surface in ideal conditions with a high inoculum put on the surface. Any questions on that? Okay, so I'm going to move on from here and get to the next question, which is hiding behind my thing. So this is a question about somebody who's a quadriplegic living at home with a it sounds like a live-in caregiver and one full-time, and what precautions should be in place. And this very much depends on several factors. So the first factor is within households, we don't necessarily expect people to do social distancing within households. So for example, my husband and I aren't staying 2 meters apart. My kids and I aren't staying 2 meters apart. We sort of consider the household as being one infectious unit. So if you're in the household and the other person's in the household and you never go out, there's no need to do any precautions. You have the same risk. If you have somebody who's going out into the community on a regular basis, maybe somebody is comes into work and has children and relatives and whatnot. In that situation, right now, we're recommending that everybody wear face protection and eye protection. That's as much to protect you as the receiver of care as it is to protect the caregiver. That's probably going to change in very short order. And the reason it's changing is because the other variable is how much virus is circulating in the community. Right now, we have very, very little virus circulating in the community. When you look at the BC CDC reports, you can see that the positivity rate is around 1%, and that includes all the people who are repeat testing, who we knew were positive, and people with symptoms. So people who are walking around the community now without symptoms are extremely unlikely to have virus. And so it's quite likely that our recommendations on what people should do when they're walking around the community and then caring for somebody, what precautions they should wear, because the benefit of those precautions becomes increasingly less valuable as the degree of a virus circulating in the community drops. Those are subject to change. And again, this is where we really need to rely on our public health colleagues to tell us what's going on so that we can decide whether we need to increase our precautions or not. So, anyone have any questions on that?
We did have a question, sorry, earlier,
Okay, yeah.
just when you were sharing your screen, from Clayton. He asks, how long can the virus stay on doorknobs or keyboards?
So again, we would use the plastic in that graphic to stand in for that. So left completely unchecked with a huge inoculum of virus, it's up to 24 hours. It's unusual for somebody to actually have that degree of inoculum of virus, supposing that they are carrying it and they touch a keyboard. You're going to have a much lower inoculum of virus, so it's going to be less than that. And also, if you're in a place with, if the keyboard's in UV light or whatnot, it's going to be lower still. Having said that, if you are sharing keyboards with multiple people and you don't know who's touched the keyboard, it's strongly recommended that you be able to clean those keyboards. And you can get the, there's plastic sheets you can get to go over keyboards that you can wipe down. Regular cleaners will kill this virus very easily, so it's very simple to get rid of. So if you are sharing keyboards at work or you know, somewhere else where you might be working, then wiping the keyboard down is a very good idea. The other thing, if that's not possible, is washing your hands. You cannot get the virus through your hands. So even if your hands touch a dirty keyboard, as long as you wash your hands before you touch your eyes, nose, or mouth, you will stop the transmission that way. So you have multiple layers of protecting yourself against potentially contaminated surfaces. Any other questions?
Not at the moment. Thank you for that.
So the next question is one of my favorite questions about kids. Somebody who's a high C spine, spinal cord injury, parent of 2 children, and is it too risky for them to return to school before a vaccine exists? So I have 3 kids. I recognize how poorly they control their own secretions. And so I understand the concern. The first thing to know about kids is that they themselves are at extremely low risk for disease. Kids just don't seem to get sick with this. There have been no pediatric deaths in Canada despite 70,000 cases and climbing. So I'm not worried about the children. There have been several studies, most recently one in Australia, where they actually had children at school with the virus circulating. And despite having children come into school testing positive for the virus, when they looked, they didn't see any transmission either to other children or to adults. So it seems like children are less likely to transmit disease. However, if you look at another study in Italy, children seem to get the disease as frequently as adults. So there's a degree of uncertainty. Chances are the risk is relatively low, especially if your kids, I see grade 1, 3. So if your kids are able to respect the rule of once they come in the house, they wash their hands, and they're reasonably willing to sort of tell you if they have symptoms and stay away from you if they do, then it's probably very safe to send them back to school. Certainly waiting until a vaccine exists might be problematic. Well, I'd love it if we get a vaccine next week. There's no guarantee we're going to get a vaccine for quite some time. The most sort of optimistic projections would be in about 2 years. So that, well, maybe 18 months now that we've been working on it for a few months. That's very, very optimistic. So it's entirely possible we might be looking at 2 or 3 years or longer before a vaccine comes in. to a certain extent, there's going to have to be a degree of risk management for kids going back to school. Okay, and I got a second same one. So I just want to, there's a bunch of questions about the immune compromise and spinal cord injury. As far as we can tell, yes, spinal cord injured patients have risk for numerous infections, but it does not seem that COVID is particularly affected by spinal cord injury, which is good. Those of you who are on ventilators, obviously you're at risk for any sort of respiratory viral infection, just because you're already at risk for getting pneumonias and whatnot. But the spinal cord injury in and of itself is probably not your biggest risk. Any questions on that?
We do have one question from
Okay.
Sharon. She asks if the asymptomatic or infected children unknowingly bring it back to immunosuppressed parents, what should we do? Would children wearing masks decrease the risk to an acceptable level?
Yeah, so as like I said, the jury's a little bit out. It seems that children are much less likely to spread. They probably just have less viral load. They tend to have very good immune systems, and they tend to clamp it down. Children in masks will not save you anything, unfortunately. In order for a mask to do a decent job, people have to not touch the mask, keep it on at all times, never touch their eyes or mouths, never scratch their nose, and children are incapable. Honestly, healthcare workers have a hard time doing that over short periods of time. Having children wear a mask for that period of time, they're going to self-contaminate, and then it actually hasn't done what it's supposed to do. So we're making children wear masks. Unfortunately, it would be nice if it worked, but I suspect it won't. And there's very little research suggesting that children wearing masks makes any difference. It's been used in the community. Even they're wearing masks routinely. Only has a very, very small impact on any disease transmission because of that self-contamination issue. And children just aren't sort of neurologically capable of doing that over any period of time. The best thing you can do with your kids is really to make sure that they're washing their hands regularly, especially before they eat, after bathroom, for other reasons, and when they come back from school, when they may have picked something up and sort of brought it back. Any other questions? Sorry, I'm pulling the chat thing up here. Yeah, so children have fewer ACE2 inhibitors, ACE2 receptors, and that's what was brought up yesterday in Dr. Henry's news conference. They think that might be why children have less tendency to get and spread disease. So it's entirely possible that that's the reason. It may be because of other reasons. Not 100% clear yet, but that's certainly one of the theories going forward as to why that is with kids. Okay, so can COVID get on my wheelchair? I'm nervous outside around others as many don't keep the 6-foot rule. So yeah, that's a really good point. The good news about being outdoors is that because of wind, air circulation, UV light, all of those things actually fight against the virus. There seems to be some signal that being outdoors is protective. That sort of fits with our previous knowledge about respiratory viruses, but also we're seeing just less spread. All of those images of people on Kitts Beach, there was no big swell of disease after that, and that's probably just because being outdoors makes it much harder for the virus to transmit itself. It gets blown away, it gets zapped with UV light. The humidity and environmental conditions aren't necessarily right for spread. So having said that, it's not, somebody being within 6 feet for a very short period of time is also most likely not a risk. I mean, if they sneeze on you actively as they're walking by, that's obviously quite problematic. But passing on the sidewalk, which can often be challenging, especially if you're in a chair, that's actually not a risk for transmission. The viruses don't jump out of people onto your chair. They stay in the person's respiratory tract unless they spread it either by touching or by sneezing, coughing, or otherwise getting respiratory droplets on that surface. Having said that, if for whatever reason you do get something on your chair, it's the same rule. Just having it on your chair will not infect you. It's once it gets on your chair, on your hands, or on the hands of your caregiver, who then goes and touches a mucous membrane, that you have a problem. So if you're concerned about your chair, by all means, you should certainly be wiping your chairs down whenever you can. And then if you do have somebody sneeze on you or cough on you, that's a great opportunity to either wipe your chair down yourself or have one of your caregivers wipe your chair down to make sure that any virus is wiped up. And again, this organism is very, very susceptible to cleaning. So any sort of common standard garden variety cleaning fluid would be enough to wipe it off and kill it. Any questions on that?
We do,
Yeah.
just in terms of what you were just speaking on, Patty's wondering how long it will stay on our rubber tires for manual wheelchair users.
Oh, that's a really good question. I do not have a straight answer for that. It would be somewhere between plastic and a soft surface. The good news about a tire that's running on the ground is that you're actually getting a lot of mechanical rub on it. Which means that it's probably going to rub off quite quickly. But I would still use the same principle. If you've been rolling around, I mean, this should be true at all times, but certainly if you've been rolling around, before you touch your hands, face, or mouth, clean your hands so that anything that might have gotten on your wheels is taken off and killed. Again, very easy to kill with standard cleaning protocols. And that do people with MS who are treated with methylpred more at risk? Yes. So anybody who's on any sort of immune suppressive therapy is more likely to get any infection. And as far as we know, this particular virus is also a higher risk for somebody who might be on immune suppressing medications. The degree to which that's important and how much extra risk there is, nobody can actually answer that right now, but I would presume that yes, it's a higher risk for anyone on any sort of immune suppression. I'm doing a lot of talking. Sorry about that. Touch on the difference between high quad, lower quad, high para, low para. So again, we don't have enough data to really know definitively. So I'm going to rely on sort of what I know generally. So the bigger your spinal cord injury, the harder time you're going to have to clear your secretions. And as a result, it's going to be harder if you get additional compromise in your respiratory tract to be able to breathe. So somebody who's ventilated, who's a high quad, who's trached, one, they're at risk of pneumonias at all times. That's not new. But you lack the muscle capacity to cough things out, which might be problematic in the event that you are producing more secretions because of a virus. You also don't have the capacity to sort of pull more and recruit more respiratory use if you need it. So that's certainly a potential problem. I don't know if that has borne out. I haven't seen any literature on it, but it sort of stands to reason. Obviously, the lower we go down the spinal cord in terms of injury, the less likely this is to affect you. And I would say anyone who's even a high para probably is not more at risk, except for maybe needing more care or more close contact with people because of care needs, if that's your situation. Any other questions?
We do have one just
Okay.
that's been typed in from Clayton asking if some types of hand soap are better than others.
So no, essentially, as long as you wash your hands, it doesn't matter if you use alcohol-based hand rub. That's often the easiest because you can have a little dispenser with you at all times and you can use it at all times. So that works super well. Regular old hand soap and water, it need not be an antibacterial soap. Regular soap works. The key is to make sure that you get all surfaces of your hand, so the front, the backs, in between the finger webs, which everybody forgets, and the thumb web. So making sure you do all of that stuff a good 20 seconds and then a good rub underwater. That will also get rid of the virus. The best hand washing is the one that you can do regularly and reliably. So if you're somebody who has difficulty getting to a sink or under a sink, then make sure you have the alcohol-based hand rub. If that's not a problem for you and you prefer hand washing, which I personally prefer hand washing, I get a little bit of a reaction to the alcohol. So I hand wash with soap and water. Both are perfectly acceptable. Do whatever you can do. Sorry, I've lost my cursor here. There she is. Okay. I have recurrent constant UTI treatable only by IV antibiotics. Am I likely to get more ill if I was exposed to COVID? So as far as we know, no. Urinary tract infections and COVID are separate systems. Now, obviously, if you're septic with a urinary tract infection, that's an additional thing that your immune system's trying to fight off, but your immune system can actually fight off multiple pathogens at the same time. So just a urinary tract infection in and of itself should not make you more at risk from COVID as far as we know. And again, not a ton of studies on this, but as far as we know right now, that it shouldn't make a difference. So please comment on visiting with grandchildren after they are back to school and have exposure to hundreds of people. So again, I think that comes back to our discussion of children. There seems to be a suggestion that they're less likely to spread. Again, it depends on your grandchildren. Certainly, I would not have your grandchildren visit if they have symptoms of cough, cold, fever, flu, that sort of stuff. But if they're otherwise healthy, obviously you have to do your own risk assessment, but I think most people would love to see their grandkids, and there seems to be suggestion that that's okay as long as they're not displaying any symptoms. Yeah, I will. I've been asked to pull up the papers. I will send those to you, Terry, at the end of the thing. There's one in Iceland, there's one in Australia that I would be more than happy to share with the group, and Italy. Should be wearing gloves while out in public wheeling our wheelchairs. And my answer to that is, I mean, wear them if you need protection for your hands for mechanical reasons. You don't want to get sores on your hands, but there's no reason from an infection point of view, because whether it's your hands or gloves, either way, you have to wash your hands. If you wear gloves the whole time and you touch your hand, your face and your hand, mouth or nose, it's no better. In fact, it's probably worse because our hands have an immune system on them of sorts that actually protects you against contamination. Not perfectly, but better than gloves. If you choose to wear gloves, when you take them off, again, you have to wash your hands before you touch your hand, mouth, or nose. Even taking the gloves off, you contaminate your own hands, so that you need to wash your hands. Okay. Have quads in US and UK had COVID-19? Undoubtedly. And we did do a literature search, and we did try and find specific reports, and we were unable to find any. So that will probably come out in a couple of years when people have had sort of enough volume. But I have not been able to find any literature specific to people with spinal cord injury. The UK has a number of guidelines, which I'm also happy to share. Having said that, they're all expert opinion, sort of common sense based stuff, not based on any actual data. Yeah, for sure. Is it safe to go to medical appointments at the hospital, specifically Richmond General, where there's currently an outbreak? I'm very happy to tell you that Richmond General does not currently have an outbreak. It was declared over yesterday, and I just want to touch on that a little bit in that, well, yes, there was an outbreak declared. It was a very, very small transmission amongst patients in a single 4-bedded room. So it's not like the whole hospital was contaminated. That's almost never the case when there's outbreaks in the hospital. We are very, very conservative in hospitals just because of this question, and that we want to make sure if there's any evidence of transmission, we stop it and we make sure it's safe for everyone to come to hospital. So yes, it is safe to come to your appointments. There are all sorts of precautions that are being used in outpatient areas and inpatient areas. We do not admit people to hospital just because. We admit people to hospital because they're sick. If you are sick, you need to come to hospital because you need to be taken care of. If we can possibly care for somebody at home, we always do. So do not let fear of this stop you from coming into hospital, because we're actually seeing evidence of people dying of heart disease because they didn't want to come to hospital because they were so scared. So please don't do that. The reason we have people doing infection control is to prevent the spread in hospital, which has been very effective. We've had very, very few transmissions in hospital. So please do come to hospital.
I can read to you the one from Sharon here. Says, can you please comment on whether fewer children are infected with COVID-19 versus actually infected but asymptomatic?
So that's where the Icelandic paper is quite helpful. And basically, they just randomly went out and swabbed people. And children were just much, much, much less likely to carry the virus. So it seems that they're less likely to carry the virus, full stop, asymptomatically or otherwise. So that's probably the answer. Again, we're still in the learning process on this, but it seems that they're less likely to carry the virus completely. They're also probably less likely, if they do have the virus, to demonstrate symptoms.
Go ahead. Chris just was asking how much more is person-to-person breath spread versus touch/cross-contamination.
Nobody knows the answer to that because we don't, unfortunately, it doesn't come written on the patient how they got their COVID. Those are all important methods, and they probably vary depending on the context. So within somewhere where we're all using the same keyboard, fomite might be more important. In places where there's a lot of touching, it's probably touching. It really probably is context dependent. All of those are means of transmission, and then what you're exposed to is probably the more important thing for you. In terms of which is more efficient, we actually really don't know.
Okay.
Mm-hmm.
So the couple other questions that I just got today.
Mm-hmm.
So we are concerned about how to keep para-athletes safe in training programs and future
Mm-hmm.
competitions. So do you have some recommendations about that?
Oh, that's a whole interesting point of view. And I think that it's not my area of expertise. I'm going to be absolutely 100% straight with you. It probably depends on the sport. So I would argue that swimming is probably fine. In that you're in the water, it's got chlorine, you're not touching people regularly, and that would be very different than something like a basketball type situation where you're running into people and you do have physical contact. So that's one thing. The other thing is it's going to be the same principles as everywhere else in society. Don't come if you're sick. Monitor for symptoms. Don't come if people in your family are sick. And as much as possible, try and stay physically separated from people in your day-to-day life to reduce the chances of coming down with disease. The good news is that athletes are otherwise healthy people and less likely to have severe disease. But anytime you're coming in contact with people, which is true generally, you do have a risk of infection, be it COVID or any other number of respiratory viruses that we're all subject to.
Thank you. Some best ways or suggestions to clean the home, clothing, groceries for prevention.
So cleaning your home, well, I will never do it personally, so that's a separate issue. But essentially cleaning your home shouldn't change. The virus, if it came in on you, it's already on you. So at that point, it's a moot point about cleaning your home. Cleaning your home shouldn't change. If you do have people who are coming in from the outside and doing work in your home, then they should clean the surfaces. Any sort of a cleaner is fine. Soap and water is fine. So certainly recommend that. So if someone's coming in and preparing your food, first of all, they need to wash their hands before they come in, because if it's on the food, it doesn't matter what you do to the surface. But after they're done, they should clean the surface. And that's true of any other sort of care that might be necessary. Sorry, that was clothing. Routine laundry will be fine. There's nothing special to do with clothing. And then again, your chair, if you've been exposed to someone or someone's touched you, then it's probably reasonable to wipe it down.
Thank you. I know, so Gail is online here, and she is the executive director of BC Wheelchair Sports. So she asked the para-athletes question, but just in addition to that, so she was asking, would you hold off on contact sports for quadriplegics like wheelchair rugby until there isn't a vaccine, or could you see it going forward with precautions?
You know, it's an interesting question, and I think a lot of that comes down to people's risk tolerance. You could make a very reasonable case to say, no, we tolerate absolutely zero risk. We're going to wait till there's a vaccine. The upside of that is, yes, it substantially reduces the risk of infection. The downside is we don't know when a vaccine is going to come, and that means staying away from something you love to do for a period of time. I think different people could reasonably come to different answers on that. I think we can risk mitigate to the point where we say, don't come if you're ill or have sick contacts. We're going to monitor you, any number of things, and try and risk mitigate. There is no such thing as zero risk, and then people have to decide for themselves what degree of risk they're willing to tolerate to do something that they either love to do or kind of like to do, or are being forced by their mom to do, and that really is an individual decision, in my opinion.
Thanks. Okay, so what fabrics would be good to use in making masks?
So it's hard to say. There's actually some studies out there. Again, I'll have to pull them up. Nobody actually can really answer that question. People have looked at different materials for different masks. For anything that's medical, so if you're going to a medical appointment, or, you know, they should be using medical masks, full stop. Those are the only masks that are tested and have parameters and standards. Homemade cloth masks have been tested and have been all over the map, but the problem is that that depends on how you test them, for how long, with what. And so it's really hard to come up with a recommendation for that. We actually, one of my colleagues, Dr. Wong, is building a materials testing lab at VGH, and at some point he may have an answer to that, but it's a little early yet.
All right, I just have 2 questions to go, Jenna, and then you
Okay.
can, I see a couple things in the chat there that.
Okay.
Is it reasonable to expect a second wave of COVID? If so, how should we prepare?
So yes, I would say that 2, 3, 4, 5 waves are inevitable until there is some form of vaccine, if that ever happens. How do we prepare for that? Well, that's sort of the million-dollar question. And again, we're all sort of feeling our ways through this. Ultimately, there's 2 ways to end up with immunity. One is with a vaccine, which is what we would all prefer. The second is basically people get the disease and eventually we all develop herd immunity. Until that happens, there will be subsequent waves. So what can we do to prepare for that? Well, I think we do the best we can in terms of trying to understand the disease better, look for treatments, and individual members of society have to follow the public health recommendations at any given point in time to try and see what we can do to reduce spread at that point in time. And that will depend on any number of things, including how many immune people there are in the population. If there's a new strain that comes along that may be less virulent, or a strain that comes along that's more virulent, all of that's going to depend, and we have no easy way of predicting that.
Okay, last one for me. If you could just outline the process for getting a safe vaccine in Canada. Obviously, you mentioned timelines, and how long droplets remain in the air.
Okay, so droplets actually in the air actually fall immediately to the floor. Droplets, basically, they are governed by gravity, and that's why the 2-meter rule, because that's as far as we can sort of project them out before they fall to the ground. So that's not a problem. This is not an airborne disease, so there is no need to worry about it floating in the air generally around for ages and ages and ages. Once it comes out, it falls on the ground, then we either pick it up in our hands or on a fomite, or if we get it directly on our mucous membranes, that's how we get infected. So that was that. What was the second part of that question?
Please outline the process for getting a safe vaccine in Canada. Yeah.
Okay, so well, that's actually an hour-long lecture in and of itself. Essentially, there has to be a candidate vaccine that's identified. It has to be tested in animals and shown to be not harmful and effective. And then from animals, it goes to non-human primates. Same deal. After non-human primates, and they'll test it for safety in healthy volunteers. After safety in healthy volunteers, and they test it for efficacy, looking for antibody response. And that's where there's a little interesting issue, because it may be that antibody response isn't as evident in this disease, and yet you still may have effective immunity. After that, then it has to go to clinical trials for actual clinical efficacy. After that, it has to be mass produced. It has to go through quality assurance, quality verification. It has to be approved by the different health bodies. So in the States, that's the FDA, and Canada, it's Health Canada. Then it has to be distributed and administered. And so it's quite a lengthy and complicated process with multiple areas for possible problem.
Okay. Jenna, you want to go through the chat?
Sure, yeah. From Teresa in regards to hospital appointments, should upcoming routine cystoscopy appointments be rescheduled for a later date? And I think she's speaking from the island in regards
Okay.
to the island.
Now is a great time. There's actually almost no virus circulating. If you have an opportunity to go to an appointment now, now is your time. I would not delay anything right now. So I would not recommend that. If you have an appointment, go. If anything changes in terms of the epidemiology, you could always change your mind, but I would suggest that now is not an unreasonable time to go.
Great. Patty's asking if you're testing for immunity, and also if you could explain what herd immunity is.
Yeah, okay, so there actually is a plan to test for immunity. Right now, the BC CDC is working on the test it's using to test for antibodies. It's not completely validated, so that's one means of testing for immunity. The truth is the way we get rid of viruses in our body is what we call cell-mediated immunity. Unfortunately, it's very, very hard to test for that. And so what we've seen in other parts of the world is that there's a 20 to 30% antibody response, and yet those people still seem not to get reinfected. So there's probably a degree of immunity that we can't test for, and that's going to make sort of understanding the epidemiology a little bit more complicated. Not impossible, just a little harder. That is not widely available, but the BC CDC actually has been sending a survey around asking for volunteers to be tested at some point, which you can Google. Also asking about the response to COVID, et cetera. That's the testing for immunity. Sorry, and I start talking and I lose track of what the question was. There was a second part of that question.
Yeah, just explaining what
herd immunity. Right, so essentially herd immunity, any epidemic, what happens in any epidemic, this is across history and time, is you start with nobody who's ever had the disease gets introduced, and you have a period of time where people get infected really, really fast because there's no immunity. After some period of time, there's enough people that are immune that there's no people that that disease can transmit to. And so it starts to fall. And then all those people are still infected. Eventually, there's no people left to infect, and the epidemic ends. So that's the natural history of any epidemic. And so when you get to that point on the curve where the infections start to fall because there's no one left to infect, that's when you've got to what we call herd immunity, or essentially there's just so many people that just can't get infected with this disease, it stops transmitting because it just can't find anywhere to go to live. So when we talk about trying to develop herd immunity, we can do that with a vaccine where we give people a vaccine and therefore they are no longer susceptible to disease, and that's a means of getting to that point where there's nobody left to infect. The other way that happens, and always has historically until we had vaccine, was waiting until everyone had an infection, at which point they became immune and the disease would fall off naturally.
So in terms of immunity, if you do get COVID-19, do you have immunity? And if so, for how long?
Nobody knows the answer to that question. It seems like you can't get immediately reinfected. With SARS CoV, so the original SARS, there seemed to be good immunity after infection. However, regular coronaviruses, which we see coming around every cold and flu season, you can get repeatedly. So nobody knows which way this one's going to go.
Next from Jolene, we have, for those people with severe comorbidities, if a vaccine isn't possible, is it a foregone conclusion these people will eventually get COVID-19 sometime?
Not a foregone conclusion, but if there's no vaccine, what we would hope to do is to try and protect those people who have comorbidities, right? So protect the long-term care homes, protect people in hospital, and hopefully let the 20-somethings do what 20-somethings do at a low risk, and then become the buffer between people in society who might otherwise have more severe disease. Having said that, if you don't get 100% immunity in the community, there's always the risk of somebody with comorbidities getting disease.
And then from John, he's asking, why do some people seem to have extended periods of symptoms?
Just one of those mysteries. Why does somebody somebody get a really bad cold and somebody get a light cold? We don't know. And that's some of the mystery of this disease. And we, you know, people are studying it. Is it something to do with your blood type or your genetics, your nutrition, how much virus you got, where you got the virus? Those are all mysteries that we really don't know the answer to, but we're trying to figure it out.
Great. That's it that we have in written questions. If anybody does have any additional questions here in the last final minutes, feel free to raise your hand in the chat and I can unmute you and you can ask.
We do. I think there is it wasn't a question, but people were talking about masks earlier, about HEPA filters. What else? And Steve mentioned something.
The N95 versus the surgical mask.
Yeah.
That's a common question.
Yeah.
So N95 masks should only be used by other people in the room if somebody who's infected is generating aerosols, and that's usually only in the context of medical procedures. So being intubated, being ventilated. The reason for that is it takes a period of time for the very small particles that N95s filter to develop, and they're only really developed artificially. That's not something that natural disease will do. So there's no need for an N95 running around the community. Wearing a surgical mask is more than enough. So except in very specific circumstances, N95s aren't necessary. And then HEPA filters are actually used to clean environmental areas. So people who have a lot of allergies might HEPA filter their home, and that just takes out the very, very small particles from the air. Most of the very small particles in the air are not infectious. They're mostly dust or pollens or other things. So as a general rule, the only real reason for a HEPA filter is for very, very immune suppressed people who might be at risk from fungal spores or something like that in the air. They aren't particularly useful for this infection. So our bone marrow transplant ward is HEPA filtered, but for most people in most circumstances, it's not necessary.
Well, I think that is it, and that is our time for today. So, Dr. Grant, I just want to graciously thank you. I'm sure you're extraordinarily busy right now for spending your hour with us. So, very appreciative to your time. I know our whole community is, and as they are saying. And thank you, everybody, for showing up today. And I look forward to seeing everybody maybe next week.
Great. Thanks very much for listening, everybody.
Bye, everybody.